I talk a little bit about where HEAL is in the in this concept of recovery-oriented systems of care. And the first thing that occurred to me when I looked at this slide is that we really don't have anything that succinctly captures us that was included in there already. And so as a result of that, I just ended up creating something or adding something to it. And I think this sort of reflects the nature of what we do. So predominantly, what brings us to this dialogue is the discipline of harm reduction. And in many respects, I'm of the opinion that harm reduction kind of surrounds this recovery-oriented system of care. So it's intended to be there, as a buffer, so that if people fall out of some of these more traditional models of care, harm reduction is there to help connect with them and pick them back up and try to reduce some of the harmful impacts of that. But it also can really integrate into existing systems as well. And so it can connect with, the philosophy of harm reduction can be integrated into all these different components of this recovery-oriented system of care. But additionally, it feeds into this system as well. So harm reduction is really effective at connecting with people who are in active use, and as such has often served as a gateway into more traditional resources like treatment and recovery supports, among others. And so this slide really tries to depict that and the way that harm reduction both surrounds and infuses, but also feeds into this recovery-oriented system of care. So that's the first thing that occurred to me. Andy, do you want to hit the slide? The second thing that really came to me is that I felt like the slide, itself sort of plays into some of the existing language, even the culturally competent language around recovery, insofar as it seems to depict recovery as a state of being as opposed to a process. And I think from a harm reduction perspective, I feel that that's somewhat inaccurate. So I think largely we try to think of recovery as a process that begins long before somebody's ready for treatment or ready to stop using drugs. And it begins way back as soon as they start taking any positive steps. And so in the harm reduction world, we adopt a definition of recovery that really comes from Dan Bigg, may he rest in peace, from the Chicago Recovery Alliance. And that really defines recovery as any positive change, so any incremental step that a person takes to improve their health and well-being. And when you compare that against the SAMHSA's formal definition of recovery, it actually lines up really well. So I encourage and challenge folks to move away from defining recovery as a state and more towards recognizing it as a continuum, and that people can be on any part of this continuum and still be considered to be moving, in recovery and moving towards improving their health and well-being, whether that's taking care not to share a syringe or whether that's starting treatment or further along on this continuum as well. But there is some connotation of progressive change towards treatment and towards, in harm reduction, we tend to think of the end goal as being optimal health and well-being and stability and functioning, as opposed to necessarily being abstinence or treatment. So progressive movement towards stability and functioning and optimal health and well-being. Slide. So that brings us to sort of the topic of today. And I was asked to speak around increasing access to naloxone in order to prevent opioid deaths. Naloxone, and I'm honored to speak about that. That's been one of our agency's chief goals over the course of the last 3 years or so, is really enhancing access to naloxone. About 2 decades of evidence now really support enhanced access to naloxone as one of the most effective ways to combat overdose mortality as a result of the opioid crisis. So there's a significant body of evidence that's really grown up around what's called take-home naloxone, or giving people naloxone kits to take home with them in order to have it there at the right place and the right time. And that's really what we find is key from all these studies and from all of our experiences, is making sure that you have naloxone in the right place at the right time, because a delay of a few minutes can mean significant brain damage or death. Slide, please. So this is a relatively simple slide that tries to depict how naloxone actually works in the system. So essentially, as opioids attach to those opioid receptors, they cause the nervous system to malfunction, leading towards nervous system depression and respiratory depression. That is a result of too many of these receptors being covered by opioids. And what naloxone does is it comes in and it pushes the opioids off of those receptors and replaces them with naloxone. That said, it is referred to as a temporary overdose reversal medication, and that's because the half-life of naloxone is generally about half that of opioids, and so there's still a risk that someone will slip back into nervous system depression following as the naloxone leaves their system or is processed and metabolized. And so, we still try to remind folks that it's important to either have multiple doses of naloxone on hand or to be connecting them with emergency medical services as appropriate, depending on, whether they after you administer naloxone. But naloxone is increasingly effective or extremely effective, and all the studies that have evolved around it also suggest that there are no negative effects to increasing access to naloxone. So, there was sort of this initial reaction that this would somehow enable people to use drugs, and that people might use more drugs or use drugs more riskily as a result of having access to naloxone. But none of that is borne out by any of the peer-reviewed studies that have been conducted around this topic. Slide. So again, the effectiveness of naloxone comes down to having it in the right place at the right time. And I've sort of delineated four primary modalities of distribution and access that folks can take advantage of, and that we're starting to see in different communities throughout Maine. And this includes administration through through first responders, access through healthcare providers or pharmacies, but then this newer realm of community-based distribution as well. And for the rest of this, I'm just going to dig a bit into what each of those looks like. So as a result of legislation that we championed and helped pass about 4 years or so ago now, law enforcement agencies and correctional facilities, as well as municipal fire departments, can carry and administer naloxone in the event of an opioid overdose. And they have to do this in combination with training that allows them to detect the symptoms of an opioid overdose as well. Slide. It has really increased uptake of naloxone by local police departments, and the former Attorney General, as well as the current governor, really led a lot of this effort. And so, Governor Mills really spearheaded efforts to get naloxone into the hands of law enforcement officials and fire departments in order to respond to this crisis. The strengths of this model is that they're often the first on the scene in the event of an overdose when emergency medical services is reported. And it also helps to reframe the relationship between law enforcement and people who use drugs. And so it's starting to pick away at this mutually antagonistic relationship that's sort of characterized the relationship between those two entities for quite some time. The weaknesses of this sort of strategy is that, law enforcement and fire departments can't be everywhere at all times, and sometimes there's long wait times, particularly in some of your more rural regions. But also it relies on people being willing to call for emergency medical support as well, which frequently isn't the case. Slide. These are some potential enhancements. So having officers leave naloxone with the household is one way that I can think of to increase access to naloxone, but also having soft referrals to case management and harm reduction services. Slide. The other modality of distribution is really through healthcare providers themselves, and legislation passed the year after that it made it possible for healthcare professionals to provide standing orders for naloxone hydrochloride to people at risk, as well as to members and individuals of families or other persons in a position to assist somebody who's experiencing an opioid overdose. And so really by including that language of another person in a position to assist somebody experiencing an opioid overdose, that opens it wide up to the public. And that was sort of the intent there. And so healthcare, we've seen increasing numbers of healthcare providers set up standing orders within their practices in order to increase the distribution of naloxone. Slide. So this includes some of the models that we've seen emerge are prescribing upon request. So somebody will go to their provider and ask for a prescription, or co-prescribing with a pain medication. So some practices have made it standard that if you are receiving an opioid-based pain medication, that you're also receiving a prescription for naloxone. The strengths of this are that it helps to really integrate harm reduction into healthcare. So it helps to improve that relationship between a person who may be actively using drugs and the healthcare provider themselves. And it also moves us in this direction of including naloxone in every medicine cabinet, which I think is one way to have it in the right place at the right time. Weaknesses of this model are that there tend to be lower rates of uptake and utilization when it's coming through a provider. Again, coming back to the sort of the contentious relationship between healthcare providers and people who are actively using, and experiences of stigma on behalf of people who are actively using, making them really reluctant to engage with healthcare providers based on past experiences. But it can also be cost prohibitive. Slide. Some potential enhancements include highly public prescribing. So we saw Penobscot Community Health Center released a news to the media last year that they would be willing to prescribe to anybody who was interested, just needed to call their office and they would release a prescription to them, which increased access in that respect, but also co-prescribing with medication-assisted treatment. So we know and we recognize that a lot of people who start medication-assisted treatment sometimes relapse, and I think having it available in those cases is incredibly important as well, because when you're in short-term recovery is when you're really most vulnerable to an overdose death, as well as targeted healthcare services. Another law passed maybe 3 years ago made it possible for a pharmacist to prescribe and dispense naloxone hydrochloride to a person in a position to assist, so again, to the broad public. So these days, you can present at a participating pharmacy and request naloxone from them, and they sort of make the prescription to you right then and there. Right. So some of the strengths of this, again, is that it moves us in the direction of this every medicine cabinet model. And really, it dramatically expands access in rural areas where there might not be much of an infrastructure for harm reduction programs. Weaknesses include that this is an opt-in program, so pharmacies can choose whether or not they want to be prescribing naloxone in this sense. And not all of them are, and it's really led to limited uptake, and there's no central database currently as far as which pharmacies are actively prescribing. The best we could hope is to get a sense of who's been trained to prescribe, but even that doesn't indicate that they're actively prescribing naloxone themselves. And many of the pharmacies that when folks come back to us and tell us that they've tried to get naloxone from the pharmacy, we frequently hear that they don't stock naloxone for everyday distribution. And so folks will have to order it, and that just adds barriers to the process. And again, it can be cost prohibitive as well. Slide. Some potential enhancements include trying to educate more pharmacies and get more pharmacies on board. I think Walgreens is mostly there, but then in some other, particularly in rural areas, there's any number of local pharmacies who may not even be aware of the law. And then one other thing that we've been discussing a bit with the state is if the state were to issue standing orders for naloxone. And so if the state or a medical provider employed by the state issues standing orders for all residents of Maine, then it doesn't matter if the pharmacy is on board or trained. You can present that standing order to the pharmacy, and they would be obligated to fill your prescription for you. Slide. So one of the last modalities of distribution that I'm going to talk about is community-based distribution. This was made possible by a bill, again, about 4 years ago, that allows for community-based organizations to possess and distribute naloxone hydrochloride to somebody who's been successfully trained. Slide. And this really takes two shapes. So one is kind of that we've seen is non-targeted distribution. So these are sort of community-wide meetings or community-wide trainings where they're trying to train anybody who has an interest in having naloxone and administering naloxone. And this, again, moves us in this direction of every medicine cabinet. One of the weaknesses is that because it's non-targeted and it's going to general community members, there tended to be lower rates of utilization. So a lot of naloxone going out, not necessarily a lot of naloxone being used, though. slide. So the alternative to that is direct distribution, and this is distribution directly to people who are actively using drugs, which is a lot of what we do at Health Equity Alliance. And so, I really delineate 3 different ways of distributing directly to people who are using drugs, including primary. So, this happens through syringe exchanges, through street outreach, through harm reduction programming. In 2018, we distributed roughly 700 naloxone kits, and there are about 100 reversals reported. And so we're seeing an incredibly increased rate of utilization when it's distributed directly to people who are actively using in this targeted fashion. I also think that there's a lot of utility in what I'm defining here as secondary distribution. So this is distributing directly to people who use drugs to really pass along through their peer network. And it should be facilitated by harm reduction services or through grassroots mobilization. And I think one of the stunning examples of this over the past 9 months has been the Church of Safe Injection, led by Jesse Harvey and Dave Caravaggio, have distributed close to 1,000 naloxone kits over the course of the past 9 months alone. So that's more than we as a brick and mortar harm reduction agency were able to accomplish in the course of a year. And really, again, that's about getting it into the hands of people who need it most and making sure it's in the right place at the right time. And we've seen some phenomenal success through these grassroots organizations that are really highly connected with people who use drugs. And then there's tertiary distribution, so to settings that are more likely to encounter people with a history of drug use. So that's getting naloxone into treatment centers, recovery centers, homeless shelters, libraries, recovery houses, any setting that might contact and connect with a disproportionate number of people who are actively using. Slide. The strengths of this targeted method are much higher rates of uptake and utilization, but some of the weaknesses are that, particularly with brick and mortar harm reduction agencies, they're often confined by geography and often characterized by these anemic staffing profiles, which limit some of the impact that they can have. Enhancements could include a stronger emphasis on outreach and mobile distribution, as well as distribution through those tertiary sites. And so distribution through the homeless shelters, distribution through the recovery centers, distribution through the libraries themselves and other services that work with people who use drugs on a routine basis, but then also dedicated funding to expand that network of targeted services as well. Slide. And I think ultimately it's not about which one of these you choose. It's kind of about trying to find ways to fit all those different pieces together. Again, if the goal is to have naloxone in the right place at the right time, it takes a little bit of all of these strategies in order to see that happen. Slide. So that concludes my presentation, and this is just a list of some of the resources for folks who might be interested in finding out more, including harm reduction sites if there's a syringe exchange nearby you or a Church of Safe Injection branch nearby you. Feel free to contact us, or there's Jesse Harvey Consulting, of course. And then Main Access Points is a great organization that started trying to distribute naloxone statewide, mostly through a mail order modality. And increasingly, or not increasingly, but one of the newest initiatives is that the state itself is starting to develop a naloxone distribution network run by the state, but through local organizations. And so you'll be able to request naloxone directly from one of those organizations. I think the only one that's up and running right now is in Portland, but I believe they are starting to distribute naloxone outwards to organizations throughout the state, and all you have to do is submit a request.
Super. Well, thank you so much, Kenny. Incredibly informative as always. So thank you both for your leadership and your advocacy and for sharing that with us today. I might just ask